Well, hello, everybody. While we're getting our panel mic'd up, I'll just explain a little bit about the Psychiatry and Treatment AG subcommittee and why we even came about to the topic of assisted outpatient treatment. So I'm Dr. Stankowski, Joy Stankowski. I chair the committee with Adam Sorensen, and he and I were talking a little bit about what would the Psychiatry and Treatment subcommittee focus on. And by the way, if any of you are interested in these subcommittees, membership is very fluid. We would love to have you in our committee, and I'm sure other committees of the AT Task Force would feel the same. The more the merrier. So he and I were talking about treatment and talking about, especially after COVID, there's not a lot of mental health treatment in the community. So how do people end up getting treatment? A lot of times they get arrested, and that's how they're getting treatment. Is that the best thing? No, it's not, for all kinds of reasons. So then Betsy Johnson had talked to us before about assisted outpatient treatment. She's a great advocate for that. And our task force started talking about it, but realized there are barriers. Ohio's a big state with a lot of different counties, and easier said than done. But we thought it was such a worthwhile thing to implement or talk about, especially as a diversion from the criminal justice system, that our combined task forces put together this panel. And the point of this panel is Betsy Johnson in the middle will give an introduction of what is assisted outpatient treatment. And then Dr. Doug Smith, who is the CCO of the Summit County Adams Board. Summit County is one of the first counties to really do assisted outpatient treatment in Ohio, and he's got a lot of good experience to share. And Sarah Hyatt from Hamilton County. Hamilton County is pretty unique in that they've got a way to try to look at medications in the community, even when people aren't that interested in being compliant. So I think all three of these members have a great deal to say about AOT, and I'm going to hand it off to Betsy Johnson.
Good afternoon. Good to see you all. My name's Betsy Johnson. I'm with the Treatment Advocacy Center. Can everybody hear me okay? Okay. If you're not familiar, we're a national nonprofit based out of DC. We're actually, if you're familiar with NAMI, we're actually have some of the same founding fathers. Our organization's been around for 25 plus years. But we're similar to NAMI in that we advocate for policy change, and but the group that we focus on is people with serious mental illness, primarily schizophrenia and bipolar disorder, and even more narrowly, people who lack insight into their illness, with a condition called anosognosia, which basically they don't believe that they're ill, so they don't follow through with treatment. And it's not that they're in denial; they truly don't believe that they're ill. That's that's who we focus on. And we believe that assisted outpatient treatment really is the most appropriate treatment for this specific population who are caught in that revolving door of hospitalization and incarceration. So I just wanted to, I know we're talking a lot about AOT, and I just wanted to make sure we're all on the same page in terms of what we mean when we're talking about AOT. So I'm just going to a quick refresher. I know many of you are already familiar with it, but just to be clear so you all understand, AOT is involuntary. It's not like a mental health court in the criminal justice system where somebody volunteers to go into mental health court as an alternative to the traditional court route. So it is an involuntary program. That's not to say that people don't go into it voluntarily. If that's the case, that's always wonderful if you can arrange it that way, but it's not necessarily the case. It's a civil court order. It's in civil court, not criminal court. It's there's full due process. It's a full trial hearing. You get the you get all the same protections as you would get in the criminal justice system. It's the least restrictive setting, we believe. It's less restrictive than hospitalization, less restrictive than jail or prison, and even guardianship in some instances. It allows for a quicker return to the community. So if you're in the hospital and you're in jail and you're being considered as a candidate for AOT, it's a way to get out of those and more intensive care settings quicker. If the system knows that you're going into another setting where you're going to be monitored. You get the needed treatment that's whatever that treatment is. There's a treatment plan developed, and you're going to get what you need in the system. There's not additional treatment. It's really just a traditional treatment that's available to anybody else with these conditions living in the community. And the big difference is you're being monitored for adherence. We think every program ought to have a monitor who's responsible for making sure that that person is following through with treatment, and there's that ability then to intervene quickly. They don't have to become a danger to themselves or others for the system to be able to intervene because there's a court order. So as soon as they start to decompensate, the treatment team and the court can work together to get them, to intervene and get them back on track. There's this black robe effect, and it varies from county to county, but that black robe effect really helps get the person's attention initially as soon as they're under that AOT order, and then eventually with the treatment team working to get them engaged in treatment. The more they become engaged in treatment, the less they need to rely on that court order and that black robe effect. But in some communities, that black robe effect, the courts meet with these individuals maybe every 2 weeks, once a month, while they're getting adjusted to their treatment and they're becoming more engaged. Other communities, they use the court only when the person is starting to decompensate, kind of get them back in front of the judge, and the judge can remind them that they're under this court order, and what can we do to help to get you back on track, sort of thing. So it looks a little different from county to county. There's one last one. And then the other really important thing to remember is not only is that individual under a court order to follow their treatment plan, it's also the treatment system that's sort of under the court order to make sure that they're providing the treatment that this person needs. So if you're returning to court on a regular basis, it's not just the individual that's returning to court, but they're usually coming with their case manager or some other treatment team member. And if that person is not following through with treatment, if they're missing appointments, and the court finds out, well, it's because they didn't have transportation or something else, it's not that individual's fault that they didn't go to the appointment. It's really the treatment system. So the system knows, the treatment providers know that the court is monitoring and following these cases. So they're going to be more inclined to go that extra mile to make sure that this person gets the help that they need. These are very difficult people to serve. They don't show up for their appointments on time, if they show up at all. So you really got to go out and find them and get them where they need to be. So next. Thank you. So one of the things you often hear, well, AOT doesn't have teeth. Because it's not in the criminal justice system, you're not going to go to jail because you don't follow through with treatment. The whole goal is to keep these folks out of jail, so why on earth would we want them to go to jail if they don't adhere? But there are consequences. One of those consequences could be more frequent check-ins with the court. As I mentioned, some people may go every 2 weeks for a while, then do better, go every 4 weeks, go every 8 weeks, and then they'll go, if they're starting to slip, then they get back in court and say, hey, we're worried about you. We want to start seeing you every 2 weeks again for a while till things get back on track. The time the time that they're in AOT can be extended under Ohio law. You can be in it up to 2 years with the option to continue it. So that can be continued over and over again as needed. If they start to decline to the point where it's really impacting their ability to function in the community, they can be picked up, brought in for an evaluation, and then if need be, they can go to the hospital. Otherwise, if they're evaluated and found not to meet hospital level of care, they can go back to the community, but then get back right in front of the judge again, so the judge can remind them, listen, you almost went to the hospital. What are we got to work together to make sure that doesn't happen again. So there are consequences. Real quickly, I brought some information with me. I have it over there. I've got some really rich data, mostly out of the state of New York. Well, we've got it from all over, but the New York data is really good because they've had Kendra's law in effect for over 20 years, and they have under their state, it's mandated in New York, so their programs have to report out to their legislature every 5 years. So we've got lots of great data out of them. But there's a sheet in the back that kind of goes through all the research if you're interested. And on the back side are all the citations. So if you don't believe me, you can check it. Next one. Okay, so real quickly, there's 3 paths to AOT. The first one, most common, is coming out of an involuntary hospitalization. That's the easiest because you've got the person's been stabilized, you've got all the medical documentation to demonstrate that they meet criteria, and then they go right from the hospital into the community with a treatment plan in place and a treatment team. The second one is directly from the community. Under Ohio law, anybody can file a petition for AOT in civil court, family members, anybody. It's difficult to do. I'll tell you, because this is somebody who's not in treatment, so you don't have the medical documentation to make the case to court that they meet clear and convincing evidence. So as much as we wish it got used more, it's understandable why we don't. And then the last one is the one we're here to talk about today, is a diversion from jail, and more specifically an alternative to competency restoration. And I appreciate Magistrate Doggett earlier talking about, what we call this thing, and dismiss, a lot of people call it dismiss and refer or dismiss and transfer. And we really think, it's got to be called dismiss upon civil commitment with AOT. It's not enough just to transfer a case to civil court if you don't have an AOT program to put that individual into. If you're just putting them in the hospital for a bit while they get stabilized and then releasing them back to community with an appointment card to follow through with treatment, that's not going to work for the population that we're talking about. So some of the benefits, clearly it opens, we all are here because we're worried about the access to state hospital beds. So using this model, you're going to be opening some of those beds for others, more acute patients. It improves outcomes. We just kind of went over all those reductions and arrest reductions and hospitalizations, reductions in homelessness, victimization, all that. And then it saves money. Of course, they're not in expensive care for as long. But also, and I don't know that Ohio is really under threat to this, but there are some states that have gotten sued by the Department of Justice for keeping people in jail for way too long pending competency restoration. I think the state of Washington just paid a $100 million fine for that very thing. So next. So just real quickly, who are we talking about? We're talking about people who meet criteria for civil commitment. They're danger to themselves, danger to others, gravely ill. They're not a risk to public safety. They're not a candidate for mental health court. Mental health court, if that's available, then absolutely go that route. They do have more teeth. They're unlikely to be restored to competency. They have a history of lack of adherence due to this lack of insight. And they can understand what the court is ordering them to do. So that's what we're talking about. Folks basically caught in that revolving door. I thought it was funny with Michael's presentation earlier where he was talking about people who aren't suitable for outpatient civil for the competency restoration. So these are the folks that were in that list that he had, that these are folks who aren't good candidates. This is who this is for. So that was perfect because they line up perfectly with our list here. So quickly, how does this work? We've kind of just heard it, so I don't want to belabor it. So they meet all that criteria we just talked about. Hopefully, they're going to be hospitalized. If they meet that criteria, chances are they need to be hospitalized at least for a little while just to get stable, but not always. And I know that's not an option in all counties in Ohio. But hopefully, they're going to the hospital not for long stays to be restored to competency, but just short stays to be stable. So when they come out, and that decision then is made by the prosecutor. Hopefully, if they meet all these conditions, then they'll be willing to dismiss, and then the petition is filed, hopefully by the prosecutor, but if not, it could be the hospital, it could be the mental health system. It doesn't really matter as long as it gets filed. And then once it's clear that this individual is appropriate for AOT, then the prosecutor would dismiss the charge. And then next. So the person then, next step is they would engage in treatment. And we're not saying they adhere to treatment. I just want you to hear me because there's a difference between adhering to treatment and engaging in treatment. Because they could be following their treatment plan, but telling their psychiatrist, at their monthly appointment, listen, doc, the only reason I'm taking my medication is because I've got this court order. Well, if that's the case, then they're not engaging in treatment. They may be adhering. So you got to continue that until they start to make that connection in their head. You know, by following this treatment plan, my life is improving. You know, they might not have this epiphany that, oh my goodness, I've got a mental illness, I better take my medication. But they can make that connection with the help of the judge, with the help of the treatment team, that by doing this, my life is improving, my relationships are improving, my living situation, my job situation, all those things. They have to make that connection, or you're going to need to keep continuing that order. And the beauty of it for this population is you're monitoring them constantly in the community. So, you know, if we just dismiss those cases and are going back to the community without any monitoring, they're just going to wind up back in front of the court. But with AOT, you know that they're doing well, you know when they've engaged, and then that's when you dismiss the order and they go into the community, you have a celebration. And if they don't, then that's when you notify the prosecutor, and then it's up to the prosecutor to decide if they want to refile those charges and go a different route. So real quickly, where do we have AOT in Ohio? So all the counties you can see here that are in gold have, so you know, how you define AOT program varies because, as I mentioned, they don't look the same from county to county. But I can tell you in all these counties in gold, the civil court judge and the mental health the ADAM board reps are in agreement that this is something that they both support, and they've identified in their community to serve as the AOT monitor. So the AOT monitor is that glue that holds this whole thing together. You saw it in the Montgomery County image where they had sort of that one thing in the middle with everyone touching them. The AOT monitor is the one that's ensuring that everybody is being communicated with at the appropriate time, that paperwork is being filed, that hearings are being held, that if somebody's not adhering to treatment, they're starting to decompensate, that the court is being notified, that everybody knows exactly what's going on from day to day with this particular individual. So these counties have all identified somebody in their system to serve in that capacity. So two things we have, and I brought one of them with me today, is a handbook. Yeah, back in the corner, thank you, being held up over there. Please grab one of those on your way out. It's our handbook talking about how this process works and why it's a good idea. And then if you live in a community that doesn't have an AOT program, or your AOT program isn't what you think it ought to be, we have a white paper that really walks you through step by step how to implement a quality AOT program. And I'm available if you need any assistance to help.
Thank you. So, we've looked at this in Summit County long before I was there. This goes back 3 decades almost, actually, now in Summit County, doing what used to be called outpatient commitment, evolved into assisted outpatient treatment. That became the national term as well through the Treatment Advocacy Center and so forth. So we've looked at this a lot as part of the T in team. We use that a lot because we do a lot of CIT as well, which is Crisis Intervention Team. And we look at this from the criminal justice CCO point of view, the sequential intercept mapping. Really, it's intercept 0, intercept 1. Right? So you have really good treatment, and the probate falls somewhere there a little before you touch a police officer. But the police officers get a lot of training, as well as our paramedics at this point in Summit County, and of course all 88 counties also have CIT, a whole other talk. And they know then that there's when in doubt, use a pink slip. And the pink slip is the first step to getting us into a hospital, into civil commitment, and then that group goes into outpatient commitment, or AOT. So one of the unique pieces, I think, that's fairly unique in Summit County, but Betsy would know better, is that from the outset, we have decided, and we continue this today, that if somebody is so ill that they meet the criteria and they go all the way through that lengthy process to achieve civil commitments, that when they leave the hospital, they're automatically on AOT. We don't select and say, let's screen some out. We don't make that decision then. And the reason is that the law says the initial commitment is up to 90 days. And using easy math, I'll pretend they're in the hospital 10 days after that, probably a fair average. They've already been in the hospital for a number of days to get to that hearing. So when they leave the hospital, that means they have about up to 80 days to be on assisted outpatient treatment. We take that very seriously, including the up to. So we have it all set up, and I'll describe the process, so that they can end it tomorrow if the outpatient team interacts with Mr. Jones. I'll just say Mr. Jones, could be Ms. Johnson or whoever he, she, or they are. and decides they don't currently need it, or there's other reasons, then they will just end it. They'll reach out to Judge Stormer. She's our excellent Supreme Court, yeah, right, probate judge, and had been on the criminal bench previously. So she really came in with an experience that I'm not sure a lot of judges get to do both of those. And she's evolved, and when she does new day court, which I'll describe, it's really from her prior work in mental health court. She started the first mental health court in Ohio as well. So she's very, very experienced in what she's doing. Really is worth a visit if you're not doing it in your county. She's very happy, I'll just say that now so don't forget, very happy to have any of you visit and actually sit next to her on the bench during court and experience it. She's had people come from other counties, other states, and I think even 2 people now from other countries come and sit next to her in her court, which she named it New Day Court. Originally, she threw out Recovery Court. Turned out a lot of people call their various courts recovery courts, so she went with New Day Court. So I'll continue from the beginning. So we have a lot of a good treatment continuum in Summit County, always working to enhance that. We've worked with the Criminal Justice CCOE. I see Jeff Fudo here from there, and maybe some others are part of that. And we've done the sequential intercept mapping 3 different times, actually, 2 for the criminal justice side, 1 for the opiate side, and actually 4. We just recently did one for the child adolescent system, including the courts in that system. And that helps us look at, well, what else can we plug in to the gaps? And although this doesn't work for youth yet, that could happen eventually perhaps. So between CIT, and I should say we now have a new Summit County outreach team. It's a mobile crisis team with a police officer, CIT-trained police officer, CIT-trained paramedic, and a clinician who actually also had go through CIT, so they learned the team approach. And they go out now every day, weekdays, on first shift for now until we expand it, 8 weeks so far, going way better than we would have expected, I think. And they also have transported, out of 129 encounters as of last Friday, that was the end of the first 8 weeks, they've transported 29 times. It's a standard vehicle, extended cab Ford Expedition. Basically, they sit next in a regular seat. They're not strapped down. It's not an ambulance. It's not a cruiser. It's a different kind of vehicle. And the team makes the judgment based on safety, of course, their own and the person's. So just as another example, they've had to pink slip a number of them, of course, and then that may trigger them into this same process. So if you've got, we had in the beginning, this is why I mentioned this, we had reticence in the beginning, my beginning at least 12 years ago at ADM board with some chiefs of police, and so we're not thinking police should pink slip. And we've really spent a lot of energy disabusing them of that thought that when in doubt you should pink slip. You're not going to get sued for doing a pink slip. It's a low bar threshold and so forth. And that has worked very well. So that has helped us in the background as we've worked to enhance our AOT program. So number 1, everybody who ends up civilly committed ends up on AOT. We have tried the so-called 5th criterion that's in the law now, which Betsy alluded to, the outpatient to outpatient commitment or outpatient to AOT. And really what's happened there, because NAMI, and I am on the NAMI Ohio board, so I guess you can sort of see that I got my pen even. That's my next meeting after this for the next 2 days is the annual meeting. And so NAMI's been very supportive of this as well. What's happened the few times we've tried this, where families have come in and said, hey, we really think our loved one, my brother, sister, father, whatever, needs this. By the time the family has reached the point where the illness is so exacerbated and come to us, because they get used to the behaviors a lot, we've had to actually civilly put them in the hospital against their will on a pink slip. So that's the other reason it doesn't work, is that families, not surprisingly, have a high tolerance for their loved ones. We all tend to, right? Maybe Thanksgiving meals run a little long sometimes, but we mostly do well with that. And so the net result is these people have been pink slipped. So we've not been able to test outpatient to AOT in Summit County because each time we've done it, it's ended in somebody ending up in the hospital. Just to be aware of that. So I think that's why there's a movement right now to add a lower level criterion to the pink slip. Another lecture, we're both involved in this as well, as is Judge Stormer. So the individuals end up in the hospital. They come out from civil commitment to AOT. there is a group of people that probably weren't appropriate. And so what we've discovered is once the Sudafed got put behind the counter at the pharmacy, you know this story, the street chemist came up with another way to make methamphetamine, which is a lot more toxic. And so what you see is a lot more psychosis than we used to see with your grandfather's meth, or whatever they want to call it. And so the net result is we have more illness because we thought we fixed it, and somebody mentioned whack-a-mole. You know, it's like whack-a-mole, right? We fixed one place, but we actually created, in effect, a more toxic type of meth that's on the street, and that's we're seeing that in Summit County. That's actually our second leading cause of overdose deaths behind fentanyl. And I think statewide there's a lot of that. So very, very toxic. As a result, those individuals may make it through a number of days in the hospital and even go to hearing. They're still ill. They meet criteria. The magistrate, usually in Summit County it's a magistrate, decision's made, the person's going to be on civil commitment. But by the time they leave the hospital, they look great because then that meth psychosis cleared. So there is a group, there's others in this group, but there's a group that really don't benefit from AOT, and we will end that as quickly as possible. So I don't want to make it sound like everybody should be on it and so forth. It's a small group. When I joined the ADM board 12 years ago, we had 33 people on OPC, now AOT. And we looked back to try to figure out, because I had heard there were more when I was at North Coast, where Dr. Stankowski and I were both at previously, and it was unclear what happened. So as we worked with the courts, we worked with the agency, and I'll describe that in a minute. All this communication piece is huge. The net result was we grew it, and then we added the New Day Court, which I'll also describe in a minute, back in January of 2016. So we took about a year of planning a big group. We have a quarterly meeting of our probate court, run by myself, some other people at ADM board, social workers in the hospital systems, sometimes law enforcement. Our attorney who represents our ADM board is there, and so on and so forth. Some of the public defenders are there to really look at every single quarter, what's going on, what's working, what's not working. We cover everything from guardianship to AOT, so I don't want to, it's not just about AOT when we do that meeting. And anyway, just to give you a sense of some of how do we communicate, that's part of that communication. The other piece of communication is constant, used to be paperwork, back and forth, in fact, it was so much detail. We have so we went from 33, let me finish that piece, to about 180 people now on AOT on a given day. So it's, which I think is probably close to the right number if you look at it clinically. Some people are worried it's too many, but honestly, if you do the math, 180 out of about 50,000 citizens that our ADM system touches every year, or the 542,000 citizens in the county, it's a surgical strike. It's 0.00 something percent, right? 0.0012% or something really small. So it is a surgical strike. So but 180 is a tough task for a judge and some magistrates and mostly one agency, I'll describe that, and one ADM board. It's a lot of moving parts. And so we had spreadsheets that would get updated every single week, in effect daily, but the court was communicating with one of our administrative assistants who was communicating with me, we were communicating with the judge, we were communicating with Barry Ward, who's the attorney who's been representing ADM board, I think even before I moved to Ohio in 1998, so he's very experienced. He's excellent at what he does. And so we're doing this, we finally now, we can share this at a different time for time's sake, but we have a program now called CaseWorks that we purchased from a company called 5 Point Solutions. Then they were bought by a Canadian company called Versaterm, so it's now Versaterm, and that is phenomenal. Now we can communicate in real time, and the point of this is we don't want to violate anybody's rights, or we want to know when the initial date was, when is the renewal date or the discontinuation date if we haven't already discontinued it for clinical reasons, et cetera. So we have to track a lot. And that's part of our communications. I had really good communication from the judge and your team and others, and that is obviously the key. This doesn't work in any of these new scenarios, or if they're new to you or the ones you're already doing, without that communication. And so that's really been a huge boon, and that's recent. We've really only gotten that. Sure.
Okay.
Yeah.
So it came up in the chat since we're talking about communication.
Okay.
Their clerk's office submits to the BCI the findings of mental illness. Can law enforcement see this information in BCI/leads if they pull someone over?
So my understanding is that civil commitment can end up in whatever the database is that deals with whether you can buy a gun, but I don't believe it shows up in a police database, and maybe Jeff Fudo or somebody knows the answer to that. There is, just to finish it though, there is supposed to be, and I say supposed to because I've not heard that it's worked well, there's supposed to be a Rule 95 from Trooper Hopper Act for somebody who's been found, I think it's not guilty by reason of insanity, so very, in effect, legally insane, which is obviously a technical term. That's supposed to be in the database, so if they go to serve a warrant, sadly, as we just heard with the marshals and officers recently in a different state, they know that up front. So in that case, Trooper Hopper, she didn't know information about the gentleman she went to see. Well, gentleman's probably a bad word. This guy's got, he shot and killed her. And she didn't know to be wary of this some years ago. So I believe that put into effect this Rule 95, which is supposed to end up in your database for police. I say, again, I've heard times where it hasn't. Please. Please. I don't know if you want this too.
I think you're absolutely right that, okay, the NGRI folks, we have the Rule 95 for, they do get in the BCI database, can't purchase the weapons, but they also get put into leads. What happens when an officer pulls somebody over or interacts with somebody and they put in their information, it pulls up a statement that tells them that this is a person who is not guilty by reason of insanity and under court commitment, and it provides an email address. That email address goes to me. So when that email pops up, there's usually just a statement from an officer saying, hey, I pulled over this person, this is the nature of our contact. I will look at that individual's current commitment status and notify the forensic monitor that works with that individual to close that loop and make sure that they're notified. However, for the probate court, for the folks going to AOT, there's not a parallel system right now that I'm aware of. They do get into BIC or BCI for the firearms notification, but it does not go into leads at this point.
I was just going to make sure you clarified that was only for
Yes.
NGRI.
Is this a good break point?
Thank you. Sure. I'm going to say one last quick thing, which is that I want to mention the Black Robe effect just from a psychological point of view, because I think it's a point people don't always think about. Most individuals who develop mental illness develop it teenager or later in terms of severe or serious and persistent mental illness, which means that long before that they've already learned who the authority figures are in the world, right? My 4-year-old grandson went 2 years as a firefighter, right? People in uniform, police officers, firefighters, nowadays, of course, Harry Potter is probably more than they think of a judge, but they learn that early. So the point is that the Black Robe effect is much more powerful than I think we give it credit for, because now they develop mental illness, and it's got to be pretty serious to get to a point where they're in AOT court to get civilly committed, so they haven't lost that. So that Black Robe effect is more powerful because that human being already had this experience before they got to that point in life. So I like to say that because I don't know that's so obvious, but I really believe that's part of the power. It's hard to measure, but I think that's part of the power of that. And the last thing I'll say is, so the bottom line is for communication, when somebody leaves the hospital in Summit County, they get a sheet of paper, they get discussed by their social worker, which is why they're in our quarterly meetings, and it gives them the date of their first clinical appointment. It also gives them the date of their first new day court appointment, which is within 2 weeks. We only hold it every other week, so it's going to be within 2 weeks, not within a week usually. And then that case manager, so that everybody in Summit County is assigned to one agency, even though we have many. We've allowed, I should say, other agencies to do it, and after about a year, they all cry uncle. Because a lot of case manager time, they've got to take them in. The only exception, which is about 1 out of 180 cases for us, is Child Guidance Family Solutions, who runs our first episode psychosis team, also the first of those teams in the state as well when it started. So just to finish that thought about why does it work, part of it's because we have one agency designated to see all of those individuals, all 180 individuals. So.
Do you do that with your standalone private psychiatric hospitals, which seem to be absorbing the the non-forensic cases, and does that discharge connect?
Excellent question. Yes, so you are correct. So because for years we rarely get anybody into North Coast, again, not their fault, it's a system's fault, but I think literally we have like one person at North Coast right now on civil. Historically, it was a lot more than that. So what we've done though is, yes, we have hired, ADM pays for them. We have 2 hospital care navigators, one assigned to Akron General, Cleveland Clinic Akron General, one assigned to SUMA. And we pay for the whole thing. One comes from CSS, that's the agency that does AOT. One comes from Portage Path, that's an even larger agency that treats everybody up to the point of needing long-acting injectable antipsychotics. So ill, but not quite as ill. They also, however, have responsibilities. They live in the hospitals on our behalf. They work with the discharge teams to connect everybody who comes out so we don't lose anybody in the cracks here, whether they were civilly committed or not civilly committed, that we want them tracked. They also interface with Generations, which is our next highest utilized hospital, private hospital. But anywhere in the state that a Summit County patient lands, we know about it. We work with them through our hospital care navigators. We want to make sure they come back to our probate court, to our program. So great question.
I get worried about those freestanding hospitals like Generations because they're not really tied into the system and they don't really ding the case manager and the outpatient provider, automatically when you're taking a discharge. So I don't know if you have any counties, Betsy, that you see those freestanding hospitals integrated in this AOT system. Here in Franklin, I think it's really Twin Valley that makes the referrals. It's not so much, Dublin Springs, Sun Behavioral Health, and High Hospital for Psychiatry. And that's where most of our folks are going. I mean, like by and large, it's like that's the civil cases right there.
No, you're absolutely right, Dustin. Yeah, I know Franklin County is slowly adding hospitals to that referral process,
Okay.
but it's a slower process than some of us would like. But it is, I think, and other communities the private hospitals that are feeding right into, like Richland County. Ohio Health feeds right into their AOT program. They identify candidates at the hospital. They got a great relationship with them. They're sitting at the table. They're one of these. Folks around the picture we saw earlier from Montgomery County, they're at the table identifying candidates. So it varies from county to county.
That are sort of leading the charge to make those collaborations happen.
Let me start. Okay, I'm Sarah Hyatt, and I am the Central Connection Probate Services Director. And in answering to your question, in Hamilton County, the private psych hospitals do participate, and my office actually reaches out to train them and give them the paperwork and let them know how to handle and go through the process. So the Central Connection Probate Services is responsible for the oversight of the Hamilton County Outpatient Community Probate Program. And outpatient community probate is the outdated term for AOT, or assisted outpatient treatment. Our program in Hamilton County is over 30 years old. We currently have 251 respondents in our program. And those on community probate are the severely mentally ill. I know Betsy touched on this, but I think it's important to understand that these are the folks that have the most serious psychiatric disorders, typically schizophrenia, schizoaffective disorder, bipolar disorder, often major depressive disorder with psychotic features. And again, I know she mentioned this, but it is hugely important to understand what I'm going to talk about today is that a characteristic of those with severe mental illness is they lack insight into their mental illness. The name of it is anosognosia. It is a medical term. It's a neurological condition, and it makes them unaware of the fact that they have a mental illness. It's not a choice, and that's, again, it is probably one of the most important concepts you can grasp onto as I talk about the program, because it's the huge challenge of treating these folks out in the community. They just will not adhere to their treatment plans. So today I came here to talk about one of the strategies that we use in Hamilton County to address noncompliance in the community, which has been proven, we call it the court-supported injection program. And just a little bit of history about our program. In 2017, we started seeing an increase in psychiatric hospitalizations, an increase in arrests, and we were seeing violence among those on community probate. And at the same time, we were facing a reduction in the amount of acute care psychiatric beds in our community, and we had lost access totally to our state hospital, Summit Behavioral, for civil commitments. So since failure to take medication was the most significant issue regarding these increase in hospitalizations and arrests, we developed a program to enhance medication compliance. And that is a subset of those on community probate who are on a long-acting injectable, which is effectively treating their illness. That group is required to have their injection administered in the community as a part of their court-ordered treatment plan. Now, this was a collaboration among the Hamilton County Probate Court, the Hamilton County Mental Health and Recovery Services Board, the Hamilton County Sheriff's Office, the University of Cincinnati Medical Center Psychiatric Emergency Services, our outpatient providers, and we also had representation from the probate defense attorneys. It was interesting when we started looking into it, doing the research across the country to find a model. We couldn't find one. So this was not an overnight development. It took us over a year meeting in groups, really looking closely at all the issues relevant to a program like this. And we did develop a very, very detailed procedure for it. At this point, we have been operating our program for a little over 7 years. We initially projected we would have 12 to 20 on the program. It is very much supported by our outpatient and inpatient providers, and we have now 118 on the program. So over the years, we have done studies, 3 different studies with different groups on the program who have been in the program for at least a year, looking back at their arrests and hospitalizations prior to being on the program compared to their experience in the program. And we now can confirm that our injection program is working to reduce hospitalizations and to reduce arrests. And I wanted to share those outcomes with you today. Our first group studied, we saw a 33% reduction in psychiatric hospitalizations and a 21% reduction in arrests. The second group we studied showed a 59% reduction in psychiatric hospitalizations and a 16% reduction in arrests. And that information was actually published at the annual meeting of the American Academy of Psychiatry and the Law last October in Chicago, and that's where Dr. Stankowski became aware of our program. And then our third group study showed an 86% reduction in psychiatric hospitalizations and an 83% reduction in arrests. So the Hamilton County Sheriff's Office Probate Division deputies are instrumental in implementing this program. They all receive crisis intervention training and other training regarding how to best deal with the mentally ill. They are very professional, but I would like to point out they're very compassionate with this population. They forge relationships, and I think that's really important to note because typically in mental health, our objective is to reduce the number of interactions between law enforcement and the mentally ill, but in this case, that interaction is integral to this population getting the treatment they need. Yes?
Are they in uniform when they interact with these individuals?
They are in uniform, yes. So one of the early lessons that we learned regarding due process that caused us to modify our procedure, our original procedure required each respondent to come into court so that they could be given notice that they were placed in the program and have an opportunity with the magistrate to discuss it. And we did have subpoenas issued for everyone. And what we learned very quickly is no one showed up for their court hearing. So we have modified the procedure to require that each respondent in the program receives oral and written notice. It's a standard statement in their treatment plan, and they sign for it, and that treatment plan is integrated into the court order, submitted to the court, and reviewed every time they have a full hearing. Additionally, they're all told that they can come to their full hearing as often as they want. They can ask for a special hearing. So that's really the only glitch that we have encountered. We have had smooth sailing for 7 years. We've not had any adverse incidents. I really think that is attributed to the fact that we've had so much support. Judge Winkler is our probate court, our probate judge in Hamilton County, and he took the time initially to listen to the challenges that we were having in the community getting these folks treated. He sat down, he asked us the hard questions, he brought us all together. We also have had unwavering support from our mental health board, and obviously the Hamilton County Sheriff's Office is just so supportive, and we are so grateful for their help and their support in this program. And also our inpatient and outpatient providers. We have so much support in Hamilton County for this program that we're being asked to place everybody in the program because they see that it is working. It's not a magic wand, it's not a magic bullet, but it has helped quite a bit. Yes.
Has there been any discussion of integrating clozaril or clozapine into the program?
Good question. Well, unfortunately, clozapine is not an injectable, so we don't do anything except long-acting injections.
I wonder if you get to 100% with the treatment-resistant psychosis and that 20%
It's a good thought, but yeah, it has to be in an injectable form. So given our experience in this program and given the data that we've collected, we do believe that it is best practice, and we continue to look for other strategies to help with medication noncompliance, but right now this is the one we have. It's working, and we hope to continue to be successful in it. I really thank you all for asking me to talk about our program today.
The majority of your respondents complete, I know you mentioned, Dr. Smith, that if they're not appropriate, you terminate the outpatient commitment. But past the 90 days, do you see a lot of the respondents continuing on the 2-year commitment, or does it end?
Okay, great question. So the data, Betsy showed you some of that. The data, I believe, shows better outcomes at the 6-month point. The national data, the 90 days, in fact, Judge Stormer and I said if we could be the legislator for a day, we would change the law to up to 180 days from the outset, because that's what the science says. So we have a process. By day 75, and I got rid of a lot of the paperwork and made one simple sheet basically years ago. By day 75, the agency has to decide clinically if they want Mr. Jones to be renewed or discontinued. I mostly will actually want to know if they want to discontinue him, because sometimes through ADM I hear what's going on with this individual and they think he's great, but I've heard he was in 2 ERs in the last week. And so I can reach back and say, hold on, he's not doing as well as you think he is. That doesn't happen often, but it's happened. But on the other hand, if they need to do renewals, we got to, again, protect their rights and do the paperwork and all the notices and all that. So we've got a pretty good number who they're done in the up to 90-day window. At the other side, we have some individuals who've been renewed every 2 years for the past decade because they do well. Most of them, by the way, beg for it. They do not want to come off. They say, I know myself, and I've talked to some personally because I'm interested in this whole initiative, and they'll tell me, if I stop this, I'm going to relapse. I'm going to not be adherent with my treatment program, and so I'd really like to stay on it. And they basically, the fancy word, I guess, is stipulate, right? They're willing to need a hearing. So that's been very good. That's a small group. out of the 180. That's probably 10 of the 180. And then there's some in the middle where they come in and they do need a renewal. We promote a 2-year renewal, but that isn't always what happens. But mainly because if you do another 90-day renewal, that's here and gone before you blink. All the paperwork, all the stuff, so we're like, we can end it on day 1, but we prefer you just go ahead now. But I will say that, you know how that works, right? The patient is very upset when they hear up to 2 years. The family is very happy. That's kind of how it plays, right? So, but yeah, great question. So we are always watching this, and we do have a process where the clinicians have to make a decision. So we've got a couple of weeks of time before the 90-day mark hits, so we can have some decision about continuation and so forth. And we did this even through COVID. We just had to
Do you
keep.
have one AOT monitor for 180 respondents, or do you have multiple AOT monitors?
We have no AOT monitor.
Summit
So-
County is unique.
We're unique. So the group of us are constantly in communication. We don't have a person. We've got a team, and the team is constantly monitoring. We've discussed having an AOT. We have a forensic monitor. And people are, why don't you have an AOT monitor? We haven't done that yet. I think that's something we would do if we get to 250. And I'll reach out to you because I'm very interested in the LAI program. I mean, I think if it got bigger, we need it. When we hit 200 a bit, and then we had big discussions about, okay, what are we going to do now? This is too much for the court, it's too much for a couple of people at ADM board, and so forth. So great, it's a very good question. So, I actually have a quick question for you. I'm wondering if, let's say Mr. Jones does the order, signs the order, but doesn't take his long-acting injectable, what's the consequence?
Well, so the first step would be that the case management agency responsible for supervision of that person, they will do everything they can to try and coerce them, coax them to take their injection. And following that, then they notify my office if the respondent continues to refuse. And we do what's called a motion for injection, or I would do the affidavit in support of. That is signed by our board attorney. It goes to the court. But again, communication is essential because this often moves very quickly. So then the deputies will go out, and we also have a conveyor information so they know exactly where to go. If there's any concern about weapons, animals, anything like that, we try to gather all that information. And I would note that the prescription is attached to our motion for injection, so we always know that it's up to date, and that there's a person at the case management agency responsible for keeping all that information current. So then the officers will go out. Importantly, I think it's very important to know this also. One of the things Judge Winkler was very adamant about is force would never be used to initiate an injection motion or order. So the deputies go out, they ask the person if they'll come with them. 9 times out of 10, they go. And just backing up a little bit, just being on the list is a deterrent. We have like 3 to 5 motions a month with this many people, so it's very low. Most people just, once they know they're on the list, they go get it. But anyway, so once the officers are able to get the respondent, then we're in communication with the case management agency. They always go to the case management agency first for administration of the injection. If the person should become combative in the officer's car, then they will go to our psychiatric emergency service. So this is a partnership with psychiatric emergency services and our case management agencies. So if they're able to get the injection at the agency, then that's great. And if they get there and start acting up, then they go to psychiatric emergency services. And we have all kinds of policies in place. Once if they go to psychiatric emergency services, we will immediately contact the case management agency to get the injection to PES. And make sure that PES knows the case manager's name, number, just a lot of details that happen quickly, but you would just be so surprised how easy it flows. Unfortunately, we don't have any access to state hospital beds in Hamilton County, so the people who are a danger to self and others are on community probate or are on AOT in Hamilton County. It's our only option, and that's why we have an injection program, because we just don't really have any other alternative at this point. But I would say that I am really looking forward to Governor DeWine's task force outcomes, because we have a very critical need in Hamilton County for a higher level of care. A longer acute care hospitalization is just not enough for a small group of these folks who are at danger, and they do need a longer term care in a structured, safe setting such as a state hospital.
And I just want to clarify, I didn't say they weren't a danger to themselves or others. They're not a public safety risk, so they certainly could be a danger to themselves, and certainly, by not getting treatment, they're causing harm to their brain, which is going to be harder to meet, get well again. So, if they're a public safety risk and they're out there and they're threatening the community, then probably not appropriate for AOT.
I wanted to put in, well, first of all, thank you so much to our panelists. Dr. Smith drove 2 hours south and Sarah drove 2 hours north, I think. And all of the members today, the judge, the magistrate, everybody has given up a lot of their time. So we really appreciate that. And a plug for if anybody wants to join the Psychiatry and Treatment Committee, I think we plan on continuing to discuss AOT. And certainly we'd be happy to help spread the word about resources. I was very proud when I was at the National Forensic Psychiatry meeting in Chicago and walked around and found the best practice that was Ohio. So I think that between the work we have, such as what we've heard today, and the governor's task force, that our state is really positioned to be a leader in this solving the competency access crisis.